Now it's visible.
Yes. So this is our first lecture, which is on vascularaccess and pediatric oncology, which is, I guess, even I get calls, what size of code to be used, how do we manage things. So I think we have experts who will tell us how to deal with all the daily things we tackle when we are having a chemo code for a pediatric oncology patient. So I'll start with Dr. Pankaj Dwivedi, who's our moderator today. He's done his fellowship in pediatric oncology and bone marrow transplant from Tata, Mumbai. He has been he had worked as consultant in Tata Hospital and Fortis Memorial Hospital in Gurgaon. He's currently associated with the National Cancer Institute in Nagpur. He's got a good experience of 13 years, and his interests are blood cancer, soft tissue sarcomas, brain tumors, and bone marrow transplant. So, Dr. Pankaj, over to you. Should I share the next presenter slide?
Yeah, you can share.
Yes.
So, very good evening, all of you. So, there's a very good initiative. I think, Dr. Monica, we are at a same platform and we are discussing many common things we come across day to day in a patient care. So, we have with us Dr. Purvi. So, actually, she is my senior as well. So, hi, ma'am. She has done a pediatric FNB, pediatric hematology and oncology, and is working as a consultant in pediatric hematology and oncology. And she is also honorary visiting consultant in the division of pediatric hematology oncology at LTMGH Sion Hospital. She has experience over 10 years in the field of pediatric hematology, immunology, and oncology. And she is also experienced in pediatric bone marrow transplant, benign and malignant oncological condition. So welcome you, ma'am. And we will like to have a lecture or a discussion from your side as well. Ma'am, you can share the another slide for Dr. S. Ramesh. Monica, ma'am. Next slide, please. So, I'm fortunate enough to introduce Dr. Ramesh Santhakrishnan, who is a senior, actually a pediatric surgeon. He's a head of the department in Department of Pediatric Surgery at Indira Gandhi Institute of Childhood in Banglore. He's a MS and MCH in pediatric surgery. Vast experience. He's having around 35 years of experience in pediatric surgery. And he has a special interest in MIS, pediatric radiology, antenatal counseling, pediatric surgical oncology, and pediatric thoracic surgery. He's an instrumental in establishing the Department of Pediatric Surgery at the state-run Indira Gandhi Institute of Child Health, Bangalore. And this has grown into the premier institute we know all, offering state-of-the-art surgical services at a very nominal, no cost. And currently, he's the chairman of Pediatric Endosurgeons of India. He is also associated with the Indian Association of Pediatric Surgeons, and he was a past president and secretary. And he has a many publication and so on, and editorial board of the various journal. Welcome, sir, and definitely we will learn a lot of things today from you. And our third panelist is Sister Irene. He was with me in the Tata Memorial Hospital as well, and he has done the MSc Nursing in Oncology from 2013 to 15, and he is have special interest, and he's actually she is a specialist in management of a CVET. She has done a CVET courses. She is a director of CVET courses India Science from 2016, and she has conducted numerous workshops. And she is also involved in many research work. So definitely, actually, we included her for her vast experience, and she is a key person in management of central venous access devices. So welcome, Sister Irene, and definitely we will take advantage of your experience and would like to discuss various aspects of the central venous access devices in pediatric oncology. So this is about speakers and the panelists. First of all, I think it is good if Madam Dr. Purvi can deliver the lecture about the choice of the CVETs.
Yes.
So over to Dr. Purvi.
Is my screen visible?
Not right now.
Not right now. Okay, just a minute. Yeah, I'm sharing. Now?
Yes.
So basically, it's going to be a very short talk because most of it is going to be repeated, and we have the expert Dr. Kishore who is going to talk about the various types and the surgical related issues. So I'm not going to go into the surgical aspects or how we insert and what the various devices are, but how practically we choose a vascular device not only for pediatric oncology but critically ill children in our day-to-day practice. So I'll try and cover most of the practice-based points. So we know that secure and reliable central venous access is the cornerstone in hospitalized children, be it a newborn to a critically ill child who comes, with a dengue shock syndrome. It's not only needed for monitoring, but also sometimes when we have to infuse parenteral nutrition, vesicant drugs, that is our chemotherapy, and for transplant patients. Now, what are the advantages of these central lines over peripheral veins? So what is a central line or a central venous access device? It's nothing but an indwelling device which is inserted into the vein of a central vasculature, or usually it is at the junction of the SVC and the right atrium. That is the entry point. And there are various types. So we have non-tunneled, tunneled, short-term devices, peripherally inserted catheters, and a totally implanted or the POTA cath. Now, talking about the advantages of the central venous access over a peripheral vein is, of course, it is easier to access, especially when there is an emergency. Child may be in collapse, or maybe you may not be able to get a peripheral vein in a newborn when access is difficult. So this is easier than a peripheral vein access. It eliminates, when we are talking about pediatric oncology, we need multiple venipunctures and a lot of infusions to be given, or sick children who need multiple drugs going simultaneously. So it eliminates and minimizes your need for repeated venipuncture. Increases mobility of patients during infusions. It's easier to administer outpatients, so patients can go in and come out, versus a peripheral line, they can't go out with the line. And of course, we can administer vesicant medicines, that is our chemotherapy, TPN also. Disadvantages, yes, most of them require surgical procedure for placement. There is risks associated with anesthesia and surgery. There may be risks associated, during insertion, like the central lines, percutaneously put central lines. More expensive than your peripheral vein. Everything which is in situ will require maintenance. And of course, higher chances of thrombosis and infections. Broadly, these are the three types. We have an external central catheter percutaneously placed, or the tunneled ones. Then we have a peripherally inserted central line, and we have implanted ports or your POTA cath. So what basically determines, there are a few criteria which determine why one would be preferred over the other. One of the important criteria is the duration of the access you need for the central line. So do you need something which is an emergency, and either you could do away with a large bore peripheral access, or an intraosseous when the child comes to you collapsed. That means you're just needing it short term. So for a short term access, less than 14 days, usually your non-tunnel central catheters are preferred, which may be single lumen, double lumen. If it's mid-term, that means you need to keep the child in for 14 days, more than 2 weeks to 3 months. Tunneled CICCs or PICC lines are preferred. Long-term access, more than 3 months, you're going to choose your implanted CICCs, tunnel catheters, and your ports. So this is one of the criteria where you choose which is preferred over the other. That is the duration of the catheter you need for a particular patient. Okay, so the external central venous catheters, these can be tunneled, non-tunneled, and they are usually made of a radio-opaque silicone material with the external portion of the catheter always available outside the body for access. Okay, so there are two types. Non-tunneled is usually for a short term, means you're looking only for 2 weeks, or the child comes to you in an ICU basis. Then you will prefer a non-tunneled because it doesn't require a risk of surgery. It's a blind procedure, and you don't have an exit also coming out, or it doesn't require surgery and anesthesia, versus the tunneled one. These are easy to insert and access. There is lower incidence of extravasation. Multi-lumens are available, single, double, triple lumen. So you can have many simultaneous infusions. And some of the mechanical problems can be repaired by replacing the catheter. You don't need to go for another surgery or something to remove the catheter out. And this is good for long term. Usually preferred, your Hickmans and all are preferred for your BMT patients, because you know that that patient is going to keep coming to you at least for the first 3 months post transplant. And even during transplant, if he has some complications, may need TPN, infusion of blood and blood products, as well as infusion of chemotherapy. So these are the preferred ones for your transplant patients and when there is a long-term need. Now, disadvantages are, of course, it requires frequent maintenance. You need to do dressing, you need to do the flushing. The external part of the catheter is out. So some of the patients and small babies, it may not be acceptable if they pull it, and it's less cosmetically acceptable. There is restriction of activities, and family as well as the healthcare provider must learn catheter care. So you cannot just leave it in situ and expect no maintenance. Because one part of the catheter is out, there is a higher incidence of mechanical problems. There may be accidental displacement, removals, kinks, etc. And of course, there is higher incidence of infection, as again, because one part of the catheter, the exit is out. Now, this versus your subcutaneous port. So many centers, depending on the comfortability as well as the affordability, for chemotherapy may prefer in children implantable device, which is surgically placed. And as you can see in the diagram, this will be explained that the chamber is subcutaneously there and you have to access it every time with the needle. And the catheter lies at the tip of the SVC and the right atrium. Now, what are the advantages? A, this is very good for long term. It requires less frequent maintenance. Actually, in fact, nothing required, from the patient's end, no maintenance at home, except for the first 2 weeks post insertion of the port. There is lower incidence of infection. There are lower chances of mechanical problems like kinking and obstruction may be there, but removal or accidental kinking of the catheter. It's cosmetically acceptable. Dressing and flushing is not, dressing actually is not required at all because it's implanted under the skin. Flushing also once a month it's required. Of course, the cost is an issue, plus the center where chemo ports are used, they may it is difficult to insert, so you should have an expert who is available for insertion for small babies as well as children. Since it's a surgical procedure, and another drawback is it requires a needle prick every time you need to access it. So there will be a special needle which is inserted into the chamber, and every time you need to blood draw or give chemotherapy, access of the port requires a needle prick as compared to your other catheters. There is higher risk of extravasation, and of course, once if it is infected, and there is hypotension and clinical deterioration and you have to remove it, again it's a second surgical procedure. Now the last ones are the peripherally inserted catheter lines, which are peripherally inserted. Usually the arm veins are used, and the catheter again lies into the central vein. That is this is the diagram just to depict how the insertion is done and where the tip of the catheter lies. Compared to your ports and your central lines, this is a bedside placement. In fact, at our center, not only at Apollo, but also at Sion Hospital, the trained nurses are, actually guiding this procedure. They do it. There is no risk for surgery or general anesthesia. It's a bedside thing. No repeated pricks required for access. It's less expensive as compared to your other catheters. Disadvantages, mechanical complications, obstructions, especially we see this when there is a shift in nursing staff, especially from like one shift of staff to new staff coming. We see that there is a lot of flushing with 2 ml syringes. There may be, if it is obstructed, then they try and push in the fluids. Maintenance is, that's why difficult, because you need to keep repeatedly training the nurses how to access, even when there is, for blood withdrawal, there are chances of infection. It is easy to dislodge if there is a problem with, there are fractures and also some of the times we have migration of the catheter tips. However, this is less expensive than the others, and it is generally a quicker procedure, can be removed easily whenever infected and replaced also faster. So device selection, I would like to end just by summarizing that it depends not only on the duration of the catheter use, whether it's for indicated short-term, mid-term or long-term, type of insertions, where the number of lumens, so whether it's a bone marrow transplant patient or a solid tumor, pediatric solid tumor, where they're just going to coming in for the chemos and withdrawal of sample, versus a bone marrow transplant who will need a Hickman, he will need 3 lumen at least for simultaneous infusions. And whether, most importantly, patient and provider related issues. So the family has to be counseled before we are choosing one type of central line over the other. And what is the level of comfort with your working unit. So, who is going to be dressing it, who is going to be actually 1:1 in touch with the patient for the flushing. They have to be trained. So you may put 20 chemo ports, but if there is non-availability of the coring needles at a center, for example, at Sion, we are not using chemo ports. All of our patients are on PICC lines. Versus at Apollo, most of my patients are on chemo ports. So it depends on the cost as well as the unit and the provider. So the healthcare provider and what the system of comfort is in your daycare, ultimately. Thank you. I think I'll be happy to take the questions at the end of the.
Yes. Thank you, Dr. Purvi. And it was a nice presentation and comprehensive actually introduction of all the central venous assist devices. And definitely we will discuss this thing in when we discuss our this case-based discussion is there, panel discussion. But definitely you are right that the choice depends on the duration, choice depends on the logistic you have in your hospital. Same as with us, we are mostly comfortable with a PICC line rather than a port, though in few patients we are using the port. So it is all depend on your local this logistics and the expertization and the need of the patient. So thanks, madam, and we will continue to discuss with you, and we can take the questions after the completion of the lecture or during when we discuss when we have a panel discussion. So right now I welcome Dr. Ramesh and ask him to present his presentation. I think
Pankaj, am I audible?
Yes, sir, you are audible, sir.
I know. I have a problem of uploading the video. Just tell me, can you just allow me to upload my video?
Yeah, please, sir.
How to do that? Participants, reactions, settings, more. I'm not able to upload my video. Can you?
Ankita, please help. Ankita.
Yes, ma'am.
Can you please help, sir? Guide
I've seen on the video, but I'm
Yes.
not.
Sir, is there any green colored options here screen on your tab? On your tab?
Green color?
Share screen option, sir.
Yeah. 1 second, come back again.
Yes, sir. Click on that, sir.
Listen, green color.
Green colored share screen option written on the bottom of the Zoom screen, sir.
That's what I'm saying. Only screen sharing would have come. It comes in the test, this thing.
Yes, sir. You have clicked on that share screen button, sir?
No, I don't think you have given me the option to do that.
No, sir. It's being allowed to everyone, sir. You just click on the share screen option, sir?
No, it's not coming. That's why I'm asking you.
Okay.
Share screen option is not available. Otherwise, I'm fully ready.
All right, so can I just post my chat, my Gmail ID so that you can give it to me and I can share it from my end?
No, I've already shared it to Pankaj. It's I've given them Gmail access. It's uploaded.
Dr. Ramesh, sir, can you hear me?
Yes,
can you just you're on a laptop?
Yes.
I could initially not see the share screen option, but I'm on my mobile. But when I just moved the bottom row a little to the right, I could see the share screen.
I can share if you wish. I have his presentation. Me.
Yes, please. That will be good. Please do that, sir. Yes, Pankaj, if you have, you can share it. I'll be glad to talk. Just as people are getting, I'm very, very, very thankful for.
Can you see your presentation?
The group to include me, and it's indeed a privilege. Yeah. Yes, sir. You can go to the presentation, sir. You can put it to a slideshow.
Yes, sir. Yes, sir.
Yes, sir. Thank you very much, Dr. Pankaj and Dr. Monica to invite me, because chemoports and vascular access are a passion for me. And I'm extremely privileged and gratified that I've been invited to talk. I also thank Dr. Purvi to have set the ball rolling, and I apologize for my delay. So today's discussion is basically about the CVAD, or central vascular access devices, and I would like to demystify for the general public. Can you just go to the next slide, please? Yes. So my today's talk is about central vascular access devices, or CVAD in simple, in pediatric oncology. I would like to clearly say that if there's one thing which has improved the survival of children with cancer, it is the advent of central vascular access devices. Because during my tenure and my training period, maybe about 30 years back, vascular access devices was unknown. In fact, what was commonly seen was extravasation, thrombophlebitis, necrosis of subcutaneous tissues, and finally, most of the children used to default. And hence, a single most thing which improved the survival in the last 30, 40 years, if you ask me, is the advent of central vascular access devices. Vascular access devices is very important. In fact, I remember Dr. Racha, who is a very close friend of mine in Ahmedabad, mentioning once that when he came back to India in 95 or something, when he went to Gujarat Cancer Hospital, he simply says the pediatric cancer survival rate almost doubled, not because of anything else, because of improved patient compliance. I would like to say that vascular access in oncology is indeed the cornerstone for good survival. Next, please. Next slide, please. Of which I think Dr. Purvi has already told you about the types of CVAD. One is the tunnel catheter, which is about Broviac or Hickman, and then PICC lines, which are again fairly popular, and a subcutaneous port, which is called as a totally implantable vascular access devices, which is the technical term. And we'll discuss a few brief things which Purvi has not covered earlier. Next slide, please. The commonest ones are about the PICC lines, in which basically we access the central veins by a peripheral access. It's one of the simplest ones, easiest to maintain, because most of us are used to handle this. It's fairly simple. You need to identify a good peripheral vein into which you can tunnel a simple, soft, supple catheter to the extent that you would like to participate. I mean, for it to engage, and then you can use it for a lot of vascular access devices. The advantages, I think, as Dr. Purvi and a lot of other people has so far told me, is that the access is easy, establishment is easy, maintenance is easy, but there are a few disadvantages. The disadvantages include that one, it can't be too retained for beyond maybe a month or so. One. Number two, most of these devices are fairly thin, and one, it may be difficult to put it into the central vein. And number two, in case you have to have it also, most of these devices are so thin that it can be accessed only for infusions and may not necessarily for blood sampling and other things. So there are advantages because it's easy, accessible, it is widely available. In fact, it's a little more economical because most of these cost about PICC lines cost about 5,000 to 6,000 rupees, and it's fairly easy to get and maintain. However, there are little disadvantages, as I told. So if you can use the PICC line as a stopgap between a long-term venous access children who really require only a short-term device, PICC lines are useful. In fact, the other option of PICC line is about the midline catheters, in which basically the same catheter is used, but not necessarily to go up to the tip. I mean the central vein, it may somewhere be in the midline, or it may just cross the clear. Advantage is that it may not really go to the central vein,
तो अच्छे
but
किसी
it
उधर के
necessarily
फार्मेसी से
meets
पूरा
the.
बॉक्स ही लेके
Okay, so somebody is there. Okay,
आ गए मेरे को खाने
so these are the other advantages of prick line, that again you can tunnel it a long distance to avoid or minimize the complications of the irritant drugs. Next slide, please. Other option, I think, like what Dr. Purvi said, is about Hickman in an older child and Brobiac in a small child. Basically, it means it's a tunneled catheter which is introduced, like I said, from somewhere in the subcutaneous tissue. It has got a long axis in the subcutaneous tissues, enter the central line, and is going up, almost up to the right atrium, or somewhere in the, sometimes in the superior vena cava. These again have got a two vascular access. At least most of them are dual lumen, and allows a lot of things. For example, it helps in drawing bloods, giving large volumes of fluid, and Hickman's is generally preferred, like what Dr. Purvi said, for children awaiting bone marrow transplant, and generally for hematologic malignancies. Next slide, please. The next option, apart from Hickman, next slide, please, is the Brobiac, which basically is essentially a smaller size of the same Hickman. And Grosjean is one where the tip is basically has a non-reflexing valve. Even though it's very attractive, most of us generally don't work Grosjean, because particularly it's a little more expensive as compared to the regular tunnel catheters that we get. So Grosjean is attractive, but has its own limitation because of a cost more than anything else. Next slide, please. My personal favorite is about chemoport, because in Indian circumstances, we believe that the ports are very effective for maintenance and ease. What exactly is a chemoport? It is a totally implantable vascular access device. It is housed subcutaneously. It is made of silicon and plastic, and has a titanium base at the main hub of the port. Next slide, please. The anatomy of a port is clear. Basically, it's got a port and then a catheter. The catheter can be put up to the central line. In fact, you can put it up to the length you want it and cut off what is not needed. The most important part of the port, the anatomy of a port, is about the structure of the port itself. There's in fact a valve which is very important, and it can't be accessed by a regular needle, but a Huber needle. The advantage of a Huber needle is that it is actually, the tip has a hole which is sideways, and the moment you puncture the diaphragm and hit the base, the metal base, then the whole thing is open for the central line to be accessible up to the line, to the tip what is there. And it can easily be used for both aspiration of blood, for blood sampling, for giving fluids, for giving chemotherapy drugs, and for that matter, even giving blood transfusions in most of the cases. Next, please. Why chemoport? In fact, I would like to have a case for chemoport as compared to PICC line and other things which she has said. Everything has a role, but I would like to say why chemoport? Because of the durability. It can be used for more than 2000 needle pricks. In fact, beyond what is being recommended, I've got many patients who have had a port for more than 4 or 5 years, and they come because they don't want to remove it because they love it so much. It's very reliable. It can be like what Dr. Purvi also said, that it is subcutaneously placed, cosmetically advantageous, and it is very reliable, because even a minimally trained or fairly well-trained nurse can easily access it. Less chances of infection because the whole thing is inside, no part of the port is outside. Acceptance is very good. Compliance is very high and is almost pain-free. I'm not saying that it is not pain-free, it is almost pain-free. Next slide, please. So, but as Dr. Purvi also said, and I think Pankaj and Monica will also agree with me, there's nothing without a pros and a cons. If you look at the pros of the whole thing, there's no interference. That is, no interference in the physical activity of the child. The child can continue to do whatever the child was doing, including sports activity. It requires less maintenance because it requires flush only once in a month. And cosmetically, definitely far more acceptable because it's placed fairly into the subcutaneous tissues. And as surgeons, we're definitely cosmetically more conscious, and we place in a position that is least conspicuously visible. When I say the cons, when we say expensive, that is what most of the people say. That the port is about 50,000 rupees, it's costlier than any peripheral prick line. But if you look at in the long term, as to the number of times that it can be pricked, the number of IV cannulas that is being avoided, the number of the amount of antibiotic, the amount of expenses that you're going to spend on antibiotics because of infections and subcutaneous things are going to be, definitely it's not as expensive as you thought. But definitely it requires general anesthesia, it requires implanting as well as explanting. That means it requires 2 anesthetic procedure if you're lucky, because sometimes if it is not functioning, there's a problem, maybe it may be little, you may require 1 more or 2 more for revisions of that. It's time consuming, definitely, because it requires admission, anesthesia, and operating. To put the simplest way, even though we are attached to, say, Kidwai, which is the Regional Cancer Institute in Bangalore, at Indira Gandhi Institute of Child Health, the number of cases that we actually get for chemotherapy, chemoport insertion from Kidwai far outweighs the number of the OT slots that we get. So it's not that easy. So definitely it costs time. That's the biggest cons. Next one, please. So where is it indicated? Like I think it's already been highlighted, apart from long-term TPN, repeated blood transfusions, repeated blood investigations, prolonged antibiotic therapy, but most important is the use for chemotherapy in children with tumors. Next slide, please. Next slide, please. Okay. There are several types of ports available. So if you look at it, previous one, please. Previous slide, please. So there are ports which are single lumen port, double lumen port, and next slide, please. Next slide, please. Okay. So there are single port, dual port, slim ports where we don't want, especially for small infants in ICWAP. Then most of the ports do have have metallic component, which may not be useful in children who may require MRI. So you have MRI compatible ports, open-ended port, closed-end ports, Rochon valve, which allows basically one-sided flow. That means it doesn't allow the reflux. And so many things are available, but most often what we use, what is easily available and universally acceptable, that's a single port. Next, please. Next slide, please. So method of placement. In fact, there are a lot of variations in the methods of placement. Most of the times that we tend to do is to have a direct puncture, because we are comfortable doing a central venous access by just a direct puncture. Then we make a subcutaneous incision and place. But there are places in even reputed center which is far more reliable is a venotomy. That means they make a small incision in the neck, identify and expose the jugular vein. They have a separate access to the vein through a subcutaneous tissue which is a little far away, have a skin track, enter the vein and take it. And again, when you say percutaneous, most of the times we succeed in almost 95 to 99%, including our residents, are able to get it. But of late, the use of ultrasound for guidance has gained popularity. In fact, it is now in the Western countries considered the standard of care and is definitely useful in children who are obese, have problems in venous access. So it is always a good idea to have an ultrasound as a standby when you're trying to place it. Next, please. Next slide, please. Pankaj. So again, the chemoports can be placed through several veins. For example, we prefer an interjugular or a subclavian because it's easily accessible, more reliable. Placement is much simpler because either we place in the infraclavicular area or in the right lap chest. In some of the Western countries, they even place on the inner aspect of the right upper arm so that it is not even seen in children who prefer to swim. We personally don't prefer to put a femoral port because it's fairly closer to the groin area, which generally we feel is holy grail with a lot of possible infection. There are instances where these are not easily available. So sometimes we even use an external jugular, that is by cut down, we identify external jugular and place it across. Sometimes we can even use an inferior thyroid vein. What is important is to document how you have accessed, where you have accessed, and the length that you have put, because the removal of this port may be done by somebody else, and they may not be clear about what is the extent it is put, and to make sure that the entire port. Next slide, please, Pankaj. Pankaj. Next slide, please. Yeah. So this is a simple method by which we are going to be showing that we are putting a port in the first slide. We basically got a percutaneous access. Got it. We're making a small subclavicle incision, and we are making good size port. What is important is to make a good pouch so that the skin doesn't necrose. And then we are tubularizing up to this, and then we are showing that the port can be placed inside. Next one, please. Next slide, please. And then we are making this is a slide which shows that this is the port of entry into the jugular vein. This is the port in which we are going to have a smooth subcutaneous passage of the port, and this is how the catheter comes in, and this is the place we have placed the port and put a good amount of subcuticular stitches so that it is sort of fairly acceptable. Next one, please. Next one, please, Pankaj. There are pitfalls. For example, in the port also, we may put in such a time that the whole thing may kink. The kink can happen at two places. One, at the level of the port. Number two, where we are trying to tunnel it in the subcutaneous place. So it is always better to understand that the port placement is not necessarily a cosmetic operation, but a functional operation. We would rather require a functional port than a cosmetically acceptable solution. So make sure that there's going to be no kink anywhere. Second place is sometimes they put the port with a minimal incision, not enough subcutaneous tissues, and not much of subcutaneous place, in which the skin is stretched and shiny over the port, and there's a good chance that the whole thing may break down. And we have seen quite a few patients, which is done by over-enthusiastic residents who want a minimal incision and a minimal dissection, but finally the child will require two procedures and defeats the whole purpose. Next one, please. So this is for the surgeons in the group, that for a port placement, what is necessary is to have an adequate incision, a good hemostasis, a good and adequate pouch, proper connection, and a proper fixation. Because sometimes if the port is fixed in such a way that it is wobbly, every time they access using a human needle, it may keep moving around. So good wound closure is also needed, and a dressing can be placed within a few days, placed for a few days. But important is that the port is available for use right the same day. Next slide, please. Okay, this is a video. I don't know if anybody is interested. You can see the video in which we place to show that actually we do. Okay, this is where we are planning about the jugular vein or a subclavian. This is basically a subclavian in which you are accessing the subclavian vessel, the subclavian vein, and once we put a needle and a syringe, we aspirate it, we make sure that it is in the vein. We are putting a guide wire through into the subclavian, and once it is secured, we do a little dilatation. We have taken out the needle and we are doing a little dilatation of the tract. Once it is done, the port is inserted, and we make sure that it is confirmed by means of a C-arm. The easiest clinical clue that we get, it is in the heart, is that when you see ectopics wave present inside. The moment we make sure that the needle or the guide wire is inside the central line or the desired position, we make a small incision to make sure that the entry is adequate. then we insert the port, and definitely we make a good incision in subcutaneous. You can make the finger going inside to make sure that the port is adequately made without any tension. This is just to show the position of the port. We are measuring it. We are putting a port, that a catheter. We are getting it. We are placing a few stitches on the port to make sure that it is adequately cleanly fixed. This is essential to make sure that the port doesn't displace. If you can make out, it is fairly well placed, and now the catheter is being connected. We make sure that there's going to be no kink. The catheter is being tunneled back from the port of incision, site of incision, to the site of the incision for the port. At the end of it all, we again confirm one, the position by means of a C-arm. This is how the port is being inserted now. If you can see, it's a PWA sheath into which the port is being inserted into a predetermined space, confirmed by means of a C-arm to locate where exactly it is located. The moment we know it is in the right place, we peel away the PWA sheath and make sure that the catheter doesn't come out. The moment it is done, we trim it to the level that we prefer and we connect it to the port. Again, at every level, we make sure that the port is functioning before connection, after connection, and during connection. We make sure that it functions well. So the catheter is being connected to the port. The moment it is done, with the pre-placed sutures, we make sure that it is going to be adequately placed inside the pouch. If you can make out, we are going to make sure there is a good amount of skin, with a thick skin over the port, so that the complications are much less. Again, if we make sure, before we take out the whole thing, we are making sure that the port is in position and it is functioning, and we simply close the port. And we make sure that we're going to be starting IV fluids. Most of us have a tendency to start using the port right on table and send the child to the ward with a port which is functioning, to make sure the catheter is adequately flushed and no possibility of a clot. Next slide, please. Next slide, please. Next slide, please. What are the complications? Obviously, anything which a surgeon does is not without a complication. Obviously, other places too, but we are happy to blame ourselves that there can be complications. For example, long-term complications can be port catheter disconnection. We see quite a few times it happens. Of the 500 cases and all above, we have about at least about 5 to 8% there may be complications. Sometimes we've seen the catheter and the port disconnect, and there's a little extravasation at the port side. In fact, in at least about 4 or 5 cases, we've seen that the port has disconnected from the catheter, and the catheter has gone into the heart, because that's how it goes. Then it becomes a problem. We used, of course, we utilized the help of our cardiology colleagues to use a cath lab to remove it. The catheter can get ruptured. This is particularly more, I think I need to emphasize this. This is possible when we put, see, for example, we generally prefer to put a 5.5 French catheter. Imagine if you put a smaller size catheter, and if the nursing person or who is using the port, they put a Huber needle and try to flush it at strength. The point is, since there is a smaller lumen, it requires higher pressure for it to go. And if you're not clear, if you put too high a pressure, the catheter may rupture. Displacement and migration can happen either inward or outward. Either way, it's a complication. Next slide, please. Maintenance, as usual, port of the puncture of the site of the port requires a strict aseptic technique. We have to monitor the position and the function of the port. We may have to always use a special needle like a Huber needle, which is what is generally used. Change the port needle every 5 days when in use. Proper fixation of the port needle so that it doesn't really tear. Port to be flushed after the change of chemotherapy, that is 20 to 20 ml syringe is always preferred, because if you use a small syringe, it generates too much of a pressure. Heparin lock is needed at the end of the therapy. Change of heparin lock every 4 to 6 weeks if it is remained unused. This is very important, because many of our children who finish their course of chemotherapy with a Wilms tumor or a neuroblastoma prefer to have their the catheter in. And if they, in case they keep the catheter in, they prefer to, I mean, it is very necessary, even if the chemo port is not being used, to make sure it is being flushed at the interval of 4 to 6 weeks to make sure that there's no clot. Observation also of the clinical sometimes or clinical symptoms for signs of complication is very mandatory. So it is very necessary to look for local swelling, local redness, and any difficulty in the flushing of the port, both at the insertion site at the vein as well as at the port site. Next one, please. When to remove? Because ports are so comfortable, in our opinion, to use. And so when do you remove it? In fact, there is a school of thought, basically Kidwai, the senior most oncologist there, for a God for all of us, generally is not very comfortable removing it too soon. But most of the other places, we don't want to keep it when it is really not required. That means the course of chemotherapy is over, along with the usual anticipated period of recurrence and remission being allowed. So I think we need to take it out, because if necessary, we can always put in. Otherwise, there can be incidence of complications which more. In fact, I remember at least 2 or 3 cases where the vein where it was introduced has epithelialized so much, and it has healed around the port, that during the pulling out, it was so difficult, especially at the sternoclavicular junction, and we had to send it to a cardiology institute to make sure that it is remote safety. So I think when the port is served its function, it is always safe and good to remove it. And whenever there's any serious infection or complication, like infection, thrombosis, or blockage, it's to be taken out. Any extrusion, or as I told earlier, after 2 years, or adequate use. Next slide, please. We started using chemo ports from around 2008. I still remember, because when we came with an idea with the chemo port back then, in fact, there's a lot of resistance from a regional cancer institute. They said it is expensive, or people can't afford, and who's going to be trained. It is here with a sense of satisfaction that you would say that the first few cases of port, I put it and send it across, and they realized the value. Thereafter, it was very easy. Next, more than putting a port, what is more important is for the maintenance and for use. So when Bard company or some other company offered me any sort of training in Tata, I made sure that apart from one staff nurse of ours, I send a oncology staff nurse to Tata to get trained and come back for the care of the port. Because care of the port is far more important than just placement of the port. So I think that has paved a long way, to that extent that even today, the people in the regional cancer center, unlike many of the centers, prefer a chemo port even for hematologic malignancies. Simple, because it's easier to handle, easier to send the patient home. And frankly, one more thing is what has happened is, I've got an NGO who has given me chemo ports free. That means the cost factor has been annulled, and every single child with any sort of malignancies, we get at least about 5 to 6 children every week for insertion of chemo port. And our rate of chemo port insertion is fairly high. We are not able to accommodate as many cases because ours personally is a very busy unit, and we've been using for at least more than 500, because frankly speaking, I've lost count. We use at least for 500 to 600 cases, at least so far, maybe more. The thing I know is that the district cath fellow which I come, who comes to us to give us, which is our preferred catheter, many times comes and says, sir, we have studied the statistics across the country, and I think you're one of the highest users in children. It is very satisfying, because it means a lot of comfort, not just to the treating doctors and the medical oncologists, but also for the child. The complication rates are fairly low and very much acceptable. Most of the times we use a single lumen open-ended catheter. Of course, we use a combination of Bard, Vigon, and Disticath, of which we personally prefer Disticath for more than anything else. One, because it's rugged. Number two, it's inexpensive as compared to other brands. And we have been very satisfied. To that extent, every time we use some other brand, our staff nurses and the medical oncologists call back and say, this is not functioning well. Go back to what you used to do earlier. Next slide, please. So we've been doing for children who range from almost about 2 months to 14 years with a mean age of about 2.3 years. As I told, majority of cases are actually hematologic malignancies and solid tumors, of course, Wilms tumor, neuroblastoma, rhabdomyosarcoma, and very types of soft tissue tumors, we do put it. But as I told, our oncologists, medical oncologists across the road from Kidwai, they prefer a port even for hematologic malignancies. Next slide, please. So generally we use the intrajugular vein because we started putting ports at a time when central lines were not even, at a time when CMs are not even available. So generally we prefer a right vein because it's much easier to put it from the right intrajugular, it goes in. Subclavian ones is also good. And the only proviso is in smaller children, it tends to go across the subclavian to the opposite side. And extrajugular, femoral, and inferior thyroid used, but not very frequently. They're not used. So most of the times we use a closed cell vinegar technique, it's almost 93%. And we use an open technique for hardly about 78% of children. And especially in those who are obese, not available, difficult, or in those children who got a bleeding diathesis, in which, for example, children with low platelets and where they're not very happy, then we may use an open technique. Again, CM is mandatory for all cases to make sure that the tip is well maintained, because if the tip of the catheter is much into the ventricle, it induces a lot of arrhythmias. And if it's not in the right place, it may even cause thrombosis at the end. Ultrasound guidance is highly recommended, but it's a good practice to know that you can manage without a USG guidance in most of the cases. But there are going to be difficult cases in which ultrasound guidance may be extremely useful. So it is always preferable to have an ultrasound as a standby. Next slide, please. Yes, we have got our share of complications, nothing without infection. We have got about 14% to 15% infection rate, in which we got a port pocket infection, about 2.3 port site in, skin erosion, especially in those small children in which the skin is always, the children are malnourished, and we have got. And catheter-related issues are about 10%, catheter block, venous thrombosis, migration of the catheter, catheter adhesion to vein, like I told, especially in those who come very late for catheter removal. Catheter dislodgement, yes, we have seen quite a few, but handleable. Next slide, please. We got adequate follow-up. About 92% of our children come back because they're extremely grateful to us for putting the ports. About 8 to 10% of them are lost, perhaps because of the illness, the morbidity, or mortality because of the primary disease. Next slide, please. At last, what is the message for the surgeons in the group? Or perhaps a message for others is that, yes, in my opinion, the introduction of central venous access devices, particularly the availability of ports, chemo ports, have impacted so much that I would call it a paradigm shift. So my question was, request to all people, many places, including central institutes like AIMS, PGI, they don't really use much of ports, even though they have a large number. I think it's more a mental block than anything else. So I would like to say, especially people across the country, I mean, where we have got trained and sent, all of them in very, very happy using the port. So I think you need to start small, but definitely start. Because if you don't start, you will not progress. Go back to the previous slide, please. Persist. There are going to be issues. There are going to be problems. Getting a access, placing it, problems, but persist. You will get it. If you're looking for avenues, you will find out. For example, the way I could find a donor who gives 3 ports. Yes, it is possible. There are a lot of donors. We will get it. Okay. Shoot for local regional factors. As I think Dr. Purvi was suggesting, the local people there may be wanting to use a PICC line than this. It's okay. It's okay. So it's a question of combined learning curve. Nobody is enemy to anybody. We're after all working together, and it'll happen. And definitely it's not as expensive as we think. It makes a big difference. And definitely, next slide, please. Our interest is ultimately ultimately interested only in making sure that we support the small little babies who come under our care. So after all, their happiness and the smile, which makes a big difference to all of us. Thank you very much. I'll be happy to take questions if any. Thank you, sir. My talk is over, sir.
Yeah, thank you, sir.
Thank you very much, and sorry for yes, sir. Please.
For elaborative description and the details, minute details about the port. I must accept this thing. We have a phobia to the port because of the maintenance issue, cost issue, but definitely I'm sure many of us has benefited from your lecture, and we are now more in favor of the port insertion while taking care of these small kids with a cancer or some hematological or oncological issues. So thank you, sir. We will keep you asking the questions. Here now we will start our panel discussion. I know the time is moving, so we will start it quickly. I will share my slides. I think Dr. Purvi is there. Just a minute.
Dr. Pankaj, you have the slide?
Yeah.
Okay.
Just a minute. I don't know.
Can I ask a quick question to Dr. Ramesh, sir, if he's there?
Yes, please. Yes, please. Go ahead, Monica.
Sir, do you routinely do sonographies to see any neck vein thrombus? And also after the chemoport is put, you have confirmed it in the C-arm. So do you do routinely X-rays in the ward also? So the two questions basically.
Yeah, routinely, we don't use it routinely because if the port is functioning well and if we have confirmed the position by C-arm, nothing more is required. But there are, like you said, sometimes the port is not functioning well. We are not able to flush. It doesn't flow easily. Yes, that is the time we do X-ray, ultrasound to confirm what is happening, madam.
So,
Okay.
Dr. Monica, are you able to see the slides?
No, not now. I am not able to see your screen.
Sir, will I stop the presentation from my end so that you can share the screen?
Yes, please. I think even my presentation is coming up. I think you
Yes,
need
sir.
to change.
That previous presentation is coming up, sir.
Just coming. 1 minute.
Now you can share the screen again, sir.
Okay. Is it okay?
Yes, sir.
Is it visible to all? I think.
Yes.
Okay, so with these two presentation, now the audience have a clear-cut idea about the various types of the vascularaccess, how they are going to have a vascularaccess in pediatric oncology patient. Few problems are there with the pediatric patients where the protocols are long, there is a multiple breaks, and many times we loses the vascular access. At that time, these all ports and the PIC lines, CVCs are come into the picture. So we at a different places are dealing with either a PICC line or a port or other Hickman, for example, in a transplant settings. So here we would like to discuss few cases and know the expert's opinion about these situations. So to start with this, what we are going actually to discuss today, so how to deal with this central venous devices. We will see how the nursing care is important and what are the important points we have to keep in our mind while dealing with these devices. We will take the opinion from sir as well, and then we will see how we troubleshoots the problems coming while managing these central lines, and that we have a few slides related to the catheter-related blood infections. Very important in our settings or in an Indian scenario where so much rampant infection is there, and how to manage them and how to take care of your central line. So these all, now you know that single lumen, double lumen central venous access devices are there. Hickman in a transplant setting, here PICC line and port in a general pediatric hematology oncological setups. So you know this PICC line, most of the people are using this Groshong PICC or a power PICC lines. And these are the ports. The sir has extensively actually described these ports. These are some called as a power port, which is designed for a power injection where high pressure can be applied through this power port, and the unit triangular shape required heparin flush. I will not discuss in a detail because you know this. And Dr. Purvi also elaborated when and how to choose your device. So now I will come to the case and I will ask the questions to all the our panelists. And it is a 4-year boy diagnosed with acute lymphoblastic leukemia, and he is on ICBFM 2002 protocol. He is planned for the PICC line insertion. So acute leukemia, we know, need a 6 months, 6.5 or 7 months of intensive therapy followed by a maintenance therapy. So first questions to the nursing staff actually. So this is for our nurse. What point you would like to mention in a pre-insertion counseling? So Sister Irene is there.
Yes. Good evening, everyone. And thank you to Dr. Pankaj and Dr. Monica for inviting me in this webinar. We are giving pre-insertion counseling all the patients who are going port insertion or PICC or tunnel catheter, all, because we feel that counseling is very important for compliance of this care and maintenance. So in first pre-insertion, we will assess need of vascular access. So we check the patient's vein. If it is possible, vascular veins are good, we will go for PIC insertion. If it is not possible, then port is inserted. And in the, on that depend, we are selecting the device. Then we will do the clinical assessment. Mostly we avoid port in the leukemia cases because we are thinking that if leukemia cases will put, there are multiple puncture of the port, and because of that skin erosion, what Dr. Ramesh told just now, maybe because subcutaneous bleeding is occur each time when we prick the port. So that's why we select in leukemia cases PICC. In pre-insertion counseling, we involve the parents and child also. If preschool age child is there, with the help of dummy diagram and photos, we are explaining why this central line is need. Then we are telling what are the problems with peripheral cannula, what they will face. There are some extravasation, multiple prick, and sometimes we are not able to access the vein, and it is very horrible condition that we can give the patient some medication. So next we'll explain in brief insertion procedure, where it is going, how it is doing, and what is the importance of care and maintenance. After this catheter insertion, there is need of care and maintenance like dressing and flushing. And if it is not done, there possible of complications are there. So what are the and if they are not taking care, like in proper care, dressing and flushing, if they are not coming, there will be local infection, septicemia, as well as blockage, dislodgement, like that. In short, we explain in the counseling. So because of that, parents also understood that they need to take care of this catheter, and compliance are good. After explanation of this, then we prescribe and preparation, like physical preparation for PICC, bath. A patient has to come with bath, having food and PICC inserted. For port also, physical preparation is done and written consent is taken. So this all points explained in the counseling, and due to that, I think our patients are more compliant and they PICCs are remaining maximum 1 year without any complication. Thank you.
Yes, we know that we have to explain the parents about the PICC line, what are the complications, how they are going to manage, and the most important for us is also the written consent. So this way we counsel them. And to Dr. Purvi, I would like to discuss what is the best time to consider for PICC line insertion patient with acute leukemia. Why I'm asking these questions, for example, in an induction phase, if the line is infected, very much chances, and with so MDROs are there, you might end up with the PICC line removal. So what do you think, what is the best time to consider for the PICC line insertion in patient with acute?
Usually in our patients, once the diagnosis is there, it's an acute leukemia and the platelet count is stabilized. So after the pre-phase of steroid, maybe before we start the day 8, if child is clinically stable and there is no active infection, platelet count has stabilized with the steroids, family has got enough time for the counseling, a week's time, they understand, they see other patients around with PICC line. We do the counseling and we take up for PICC line anytime between day 8 to day 15. So as early as possible.
Right. So in our setup,
clinically child is okay.
Yes, yes. So as if you see, they also mentioned in ICBFM 2002, they most of the time they after induction they put the PICC line, and so we also follow the same after induction. So it is always the comfort from the both the sides. So definitely the child, whenever you are comfortable or you think that there is a not a much of a complication is going to happen, so you can choose the time. And how you choose the venous device, you have elaborated this thing. But in case of acute leukemia or AML, what is going to be your choice?
Preferably PICC line, depending on the center also again, and the choice of the patient as well as the comfort of the unit. It's usually PICC versus port. So where PICC line is not accessible and very small baby, then sometimes as Irene's sister said that chemo port will be preferred in those subset of patients. Otherwise, we are using PICC lines.
Right. So for Professor Ramesh, sir, do you give prophylactic antibiotic for insertion of central line? Mostly I'm asking for the PICC line or even a port. When you insert a port, do you use a prophylactic antibiotics even in especially in a hematological malignancy?
Yes, sir. I personally definitely prefer, because this is a port which is going to be indwelling device, whether it's a port or a PICC line or any type of central venous access device, which is going to be inside. And definitely a child has got a possibility of immunosuppression for either before or during the therapy. So it is always safer to give chemoprophylaxis, at least perioperative, one pre-op, intra-op, and one post-op, sir.
Okay, so for like ITSA guidelines, they for PICC line, especially coating, so they don't prefer to give the prophylactic antibiotic in a PICC line.
Yes, sir. For PICC line, it may not be really required, but for the rest of the central venous access, yes, sir. For PICC line, yes, it is not really needed, sir.
Okay, and how do you consider for venous cut down for insertion of the line?
So I am very clear, sir. If you are good at getting a line, cut down is really not indicated. In fact, I think I have not done a cut down for the last, say, 15-20 years at all. So one important thing I tell my PGs and my residents and maybe my medical colleagues is, if you decide to put a PICC line, put it rather sooner than as a last resort. In fact, when a child comes in, not necessarily here, even for a newborn baby, where we think the child is going to be requiring venous access for a long time, I say the day when the child comes, preserve the best vein for a PICC line, because at long term it is better. So rather than coming as a last resort, if we can put it even the PICC line much earlier, right in the early, I think all of us are going to be happy. So the necessity, what I'm saying is, the choice of the PICC line is going to be about the duration of therapy than a lack of a vein and to come as a last resort. I hope I made my point clear, Pankaj.
Right. Thank you, sir. So now The PICC line insertion, most of the time, actually, in many centers done by the trained nurses or sometime in a pediatric surgeon or maybe any medical trained staff can done. So very strict aseptic technique you have to follow, hand hygiene, skin preparation, complete covered patient with a sterile towel and proper selections of the vein, what are the needed. So now this boy, for this boy, PICC line inserted successfully, child is happy, there are no more pricks he will get. So now further challenges, care and maintenance for the line. So I will ask sister, can you elaborate in a short the maintenance of the central line, Irene sister, and how to maintain a patency of the line?
Yes, actually, these lines require long-term catheters. This requires side care, lumen flushing. Not only side care and lumen flushing, you have to clean the needleless connector, and that protocol also required. IV set administration, that protocol also required. Collection of the blood sample in aseptic technique. First thing, non-touch technique, has to be followed. So we are cleaning the site with chlorohexidine gluconate, 2% chlorohexidine gluconate, but this is less above 1 year child. If less than 1 year child, pyodine iodine solution 10% is used because it is giving allergy to the in small children. So cleaning the site with 2% chlorohexidine gluconate, starting from the center to peripheral, approximately with 2 swabs is clean. Then it is allowed to dry completely, because if it is remain little drop also, then again it is contact dermatitis occurs. After drying the site, there is applied Tegatrum CHG. That is again chlorohexidine gluconate CHG plaster is applied, and next is flushing, lumen flushing, because we are using Groshong PACC. So next slide, sir. Lumen flush, Groshong PACC is closed tip, so there we required only normal saline. But if you are using open tip PACC, there we required heparin solution. Heparin is contained 10 international unit per ml, and maximum 40 international unit is used at a time. Frequency of the flushing.
Can you adjust your mic? Please adjust your mic.
Okay, now you can hear, sir. Hello.
Yes, you are.
So, closed tip PICC, Groshong PICC, saline flushing is done, and once in a week maintenance is okay. If open tip catheter is there, heparin solution, twice in a week flushing is required. Most 3 technique you have to follow while doing the flushing, because just flushing is not preventing any other complication like blockage and some no backflow like that. So there are 3 techniques are there. Positive pressure technique. Positive pressure technique means when you are flushing, do not empty complete syringe. A little bit saline or solution to remain in the syringe. And if it is flushed with Groshong PICC, you have to hold the pistons for 10 seconds to closing the tip wall. So there will be no blood reflux, and next time there will be no thrombus remain. And if open end catheter you are flushing, you same procedure while coming 1 ml remaining in the syringe. In the process, you have to clamp the catheter. So this is the positive pressure maintaining technique is very important to prevent blockage or no blood backflow. Second thing, after administration of blood products, total parenteral nutrition, after collection of the blood sample, surely you require pulse flushing. That is a push-pause technique flushing. And first you have to flush with 20 ml of normal saline, followed by, if open tight catheter is there, heparin solution. Same thing, in between 2 drugs, you have to flush with the saline. If you are not flushing with any 2 drugs, one by one you are giving, there will be precipitation will occur due to chemical reaction, and this also causing the blockage. So these all points you remember when you're doing the flushing, and you have to maintain the properly.
So these are a few important points to remember. For example, a blood extraction while ongoing IV infusion, always close the line 10 minutes before blood extraction, plus the lumen with 20 ml normal saline using 10 ml syringe. And there is discarding the blood according to the central line. Blood sample for culture sensitivity. First collect the peripheral blood sample, collect sample from catheter without discarding from each lumen separately. Always collect the blood for coagulation profile as last sample and with separated syringe. And final flushing. Flush with 20 ml of saline in each lumen. Final flush with the heparin as per the central line. Use separate syringe for each lumen. So site care, can you a little bit define, Sister Irene?
Yes, but because port it is only first 10 days it is required care. Otherwise, after that, once wound is healed, no need of site care. So first 10 days, ask the patient to take daily bath and tell them to dry the skin with soft, clean cloth. Cleaning if they are having available 2% chlorhexidine solution, with that they once in a day they should clean. Observe the site for any infection. So we have to instruct about the signs of infection like any redness, pain, swelling of the site, bleeding, discharge, gapping of the wound. Because this patient after insertion going home and they remain for 1 week or 10 weeks and they are not observed these things, then with more complication they will come. So these all symptoms they have to explain and send the patients with that.
Right, sister. So actually, education is very important while taking care of any central venous access devices. Where we most of the time are actually dealing with the neutropenic patient. So it is very important to take care of all these devices. Coming to the real life situations about this patient, what I have discussed recently, the child is on ICP from 2000 protocol and now on a reinduction phase, where he is going to, or he has received dexamethasone steroid, L-asparginase, doxorubicin, vincristine, and definitely the child is on a immuno or a little bit which causes the myelosuppression. So presented with a fever of 101.5 degree Fahrenheit with chills, and his CBC done 1 day prior showed a hemoglobin of 7.5 gram per deciliter. WBCR at 1200 per cubic mm and the absolute neutrophil count of 500. The platelet is 34,000 per cubic mm. How we should approach this patient with febrile neutropenia and central lines? So, Dr. Purvi, can you highlight the important point to take care of this sort of a patient?
Yes, absolutely. So febrile neutropenia, as we all know, is a medical emergency. Immediately we must admit. Now it is shown that when we are dealing with catheters, neutropenia at the time of fever associated with a catheter is an independent risk factor for a catheter-related bloodstream infection. So one keeping that in mind, and clinically, what are the signs of a catheter-related bloodstream infection? Fever with chills, immediately after infusion or 30 to 40 minutes after infusion through the PICC line, the child gets fever with chills. So that is one of the red alerts that, we may be dealing with a catheter-related bloodstream infections. There are two things I ask myself clinically. A, is this patient, how long is he going to require the catheter? So if he's completed reinduction and anyways at the end of maintenance, at the end of reinduction, I was planning to remove the catheter, I would do that first. B, is the child clinically stable or not? So if the child is having hypotension, not stable, tachycardia, septic shock, all these are indications that I would just go deal away with the catheter, versus if I need to salvage the catheter, is just in induction or maybe 1B and I know that I need 4 months more, child is clinically stable, then I would do a febrile neutropenia workup, that is your basic CBC since you've done, and your blood cultures from both the sides. So this is from the lumen as well as from the peripheral vein. And we need to document to show what is the colony count, or with the new automated machine, the differential time to positivity. If it's more than 2 hours in your catheter related sample versus your peripheral vein, then these are the pointers of a catheter related bloodstream infection. And we would start off with broad spectrum antibiotics, preferably with a gram-positive cover when we are dealing with a catheter-related infection. So either TICO or vancomycin would be added.
Yes.
Then based on the culture sensitivity, we'll decide what is to be done.
Yes, so these are very common. Actually, most of the time, patient come with this sort of a presentation. So we do what the Dr. Purvi has actually described. And we have to be very cautious while patient is neutropenic and having a fever with the central line. So then it's like emergency to deal all this thing. So few more questions regarding this scenario. Blood culture taken, he was on a broad spectrum antibiotic, but he had episodes of the hypertension. So as Dr. Purvi said, if he's a hypertension clinically unstable, it may be the indication for removal of the line. So, Dr. Purvi, can you elaborate more what we should do next if he's having a hypertension? and what are going to be the indication of line removal other than this clinically unstable child, and who are the candidates for a line salvage?
Yes. So, if you don't need the line, remove the line irrespectively. So, almost near the end of the protocol, like your child is in reinduction, I would not be, and has a good peripheral access, then remove the line. If child clinically deteriorates, so sometimes after the first or second dose of antibiotics, because of bacterial toxin release and all, theoretically they say that there is a chance of hypotension, but in you are observing the child and there is clinical deterioration, not improving with antibiotics, it is an indication for line removal. If there is any evidence of endocarditis or thrombophlebitis, if there is certain organisms, so fungus grown on the blood culture, or pseudomonas, resistant gram-negative bugs, bugs which are known for biofilms, so like your pseudomonas or your streptotryphomonas, these kind of organisms, I would are definite indications for line removal. And main thing would be how your child is. So if your child is clinically unstable, not improving with antibiotics more than 48 to 72 hours, definitely calls for line removal. And who are the candidates for line salvage? Yes, of course, when they are needing the line for a longer time, they have, antibiotic sensitive infections, clinically stable child, then we would try for a line salvage.
Yes, that is very important point. ITSA has actually published the care bundles for these patients who's having a central line. And other, I may add that if the patient is persistently growing the organism after 72 hours of the actually starting of antibiotic, that may be one of the indication for removal of the line. So line was removed because of the clinically he was unstable. In case we want to consider him for a second PICC line insertion, what is the best time for reconsideration? So, Dr. Purvi, can you highlight?
I think we can, if the child does not have any, and you've removed the line, does not have any peripheral vein access, need for the PICC line, we can insert once the child is clinically stable. So there is no this thing. Maybe at the same site we should not. There is, related to the guide wire insertion through the same tract. So avoid using the same site. But if needed and the clinical situation demands, we can reinsert.
Excuse me, Dr. Pankaj, can I add in this?
Yeah, please.
Doctor, in our hospital, what we are doing, if like patients, once we removed with culture positive, at least 7 days we are not inserting, and we will get second culture report that is no growth and patient is clinically stable, then only we insert, and that is opposite side.
So I'm coming to that point actually. ITSA has defined these things. Once you have a culture negative, patient is stable, you can reconsider for surgeon. So it's same in the line what Sister Irene was describing. So the another child is a 7-year-old boy who's having diagnosed with the RMS rhabdomyosarcoma on IRS-4 protocol, recently received a vincristine, actinomycin, and cyclophosphamide. Presented with the febrile neutropenia, PICC line showed growth of E. coli, sensitive to the most of the antibiotic tested. So salvage of the catheter decided, antibiotic lock advised. What protocol should we follow for antibiotic locks? Sister Irene, can you highlight the points?
Actually, this salvage of PICC, each thing is trial. It is not actually, if any infection is there, we should remove the central line. But for salvaging, we need the catheter, no peripheral access is there. That time salvage is done. So each institute having their own protocol. We are doing protocol. Can you show my slide, sir? Next slide.
Here is there.
Okay. So we are locking with specific antibiotic, and that antibiotics will be, if PICC is there, only prime volume. How much prime volume is there, that much dose is taken. Like example, if amikacin is sensitive, so amikacin 250 vials in, from there 1 ml we are taking, that is 125 mg, and just instilling 1/2 ml in the PICC, and if there is the port 1 ml, because prime volume is concerned for that. And before putting this antibiotic, we need to flush catheter with heparin solution, any catheter, if Grosjean or open end catheter, any type of catheter, we need to flush with heparin solution, that also with only 2 ml of heparin, not more than. Why? Because we don't want to mix bacteria in the systemic like that. And remain to keep for 24 hours. So every day you have to do this procedure for at least 6 days. And on fourth day of antibiotic, we are collecting the blood sample for culture and sensitive. Again, 4th, 5th, and 6th day continuously. And if 2 reports shows negative, then we are using this catheter on after 7 days or 8 days. So we made like this protocol.
Right. So there is a actually we are going over the time, so I will finish it quickly. So we are using this antibiotic log, and there is a good protocols to use this thing. So common issues with the vascular catheter. Irene, I think I'm sharing your slide. So it can be occluded, the phlebitis can be there, or contact dermatitis may be there. So the occlusion may be a mechanical or positional, thrombus, or maybe the fibrin sheath is there, and medication precipitate is there. So prevention is the most important. Flush with adequate amount of solution. Use pulsatile flushing technique, what the sister told recently. Be aware of a solution compatibilities prior to infusion. So this is very important point to see the compatibilities or incompatibilities between the two solutions. What is going to be the treatment of the occlusion? Eliminate mechanical cause like kinking, clamping, pinching line. Do popping procedures and ask the patient to change position or cuff it. Instill thrombolytic injections. If chemical, use soda bicarb and normal saline 1:1. The phlebitis, this is very common in our D2 practice, the acute inflammation of the internal lining of the vein when the inflammation is caused by blood or clot. After it is called a thrombophlebitis, pain, swelling, redness, tenderness, presence of venous. These are actually common signs when drug extradition is there. So you have to be cautious whether it is because of the chemical, what chemical is causing this phlebitis. How we manage is application of the HAP gel or thrombophobe, ointment, glycerin max sulfate dressing, tablet Flogam, elevation of the arm, flush the catheter with normal saline, not to put a pressure on affected arm site till the symptom resolves. These are the contact dermatitis we come across in a few patients. So you know what are the signs and symptoms. There may be dry, scaly, flaky lesion, blisters, darkened and leathery skins, and extreme itching. So what is the management? Always allow the antiseptic chlorhexidine to dry completely. Consider changing antiseptic solution to providing iodine plus alcohol. Use cortisone ointment plus dressing with a cotton cloth plaster. So this is about the management or troubleshooting of the problems we have while managing the our central venous catheter. So Dr. Monica, how much time we have to discuss? If there are some questions, I can see.
Dr. Pankaj, we have overshot actually. So you have
actually, Dr. Monica,
you can, yeah.
may I ask one question?
Yes, yes.
Yeah, I'm Dr. Amit. So, sir, Ramesh, this is for you actually. So, many
Yes.
times we have a situation like we are trying to use access a PICC line and then flow. So, question is, sisters ask that shall we use that line for chemotherapy? If
We are not.
I'm saying the audio is broken.
what can the cause for this, and should we use that? Oh, sir, I was asking if when using a PICC line, they have forward flow of fluid, but there is no back flow. Should we using that line? And what is the cause of that?
So
Am I audible, sir?
it can be a small clot at the tip. Sometimes it could have gone a little further deep. It's always safer to make sure that you're going to use it only if there's a backflow. But there are instances sometimes, I mean, in a critical condition like what was identified. So if there's no issues, no complication, you can flush it, you can do. Sometimes what we have done is we injected a little contrast to see is it in the right place and is it patent. You can just use a little contrast, IV contrast, and put it in the port to see where is the tip and to see if it is patent. So this also we tend to use it, sir.
Dr. Amit, I can answer you.
Yes, madam, please.
Your PICC is open end catheter or close end catheter? PICC,
So
which
if
PICC?
it is open end, if it's open end or close end, both the cases, can you answer that?
Okay. If close end is there is less chances of thrombus on the tip. maybe wall opening is problem is there, and it is external. If external, you are seeing that length is same. It is not big length you are finding outside. That means tip is in same position most probably. So when you are putting, you are writing how much you are inserted inside, and same size is you are looking afterward also. So forward flow is there, so no need to worry about that. You can administer 100 ml normal saline. After 100 ml normal saline going freely and no other pain or nothing is there, you can administer the other drugs also. And open-ended, there will be thrombus. So forward flow is there. You can, same way, if it is length is outside, length is finding same, not a more extra length you are finding, and TP is correct. You can give the saline for 100 ml. That saline is freely is going, no fluctuation and no problem is there. You can give, administer the things.
Okay, thank you, sister. One more thing, like at what point do we can we try to manage a fracture of the cases line? Is it possible to establish a fracture every time, or is there some?
Groshang pick line, we have the repair kit extra, so we can repair it, but other pick line we don't have, so we need to remove that thing. So Groshang pick line extra, you can ask the repair kit and you can salvage the thing. If it is outside and not close to the insertion site, very away from the insertion site is there. If a little bit pulling also, that tip is not differ from normal position, it is not going, you can repair it.
Any more questions from the audience? So there was one question from Dr. Faiza about the antibiotics. Dr. Ramesh sir, what is the protocol at your institute? How many doses do you give, or do you give any antibiotics to the chemopod patients?
As I told, for chemopod, I would rather err on the side of safety by giving antibiotics perioperatively. That's one before induction, and definitely at interval, maybe one post-op. So I prefer to err on the safety, even though you can classify it as a safe surgery, because the port is one which is going to be long-term affair. I would rather make sure there's going to be no lurking infection, and this comes at a very short cost.
Okay. So Dr. Pankaj, any questions?
I think it was a good discussion, and I don't think if anybody has having more questions, so we can share with them, and we can share the email of sir and all the faculties, so they can directly ask them the question. I think this was a very good interaction session. Thanks to the panelists and the speaker, Purvi ma'am, Professor Ramesh, and definitely the organizer, Dr. Monica. So it is now.
Thank you everyone. Thank you, Dr. Pankaj.
Thank you, Monica, and I really enjoyed the presentation and good exchange, because as long as, for example, when we could not see the necessity or the popularity of the PICC lines, but now we can see the other side. I'm sure you can see our side. I think it was an excellent exchange. Thank you very much for the initiative. And I really enjoyed Purvi's talk as well as your interaction. And I should especially thank Dr. Pankaj for being so patient with me that even I said it late and he got it presented. Thank you very much, all of you, please.
Thank you everyone. Thank you.
Thank you so much everyone for giving us the opportunity to host the session. We'll have you again on our platform very soon. Thank you so much.
Thank you, Ankita, for letting us overshoot more than half an hour. Thank you.
Thank you so much, ma'am. Good night, everyone.
Good night, everyone. Good night.